Bruce Arrell's my name. I'm a professor of general practice and primary healthcare at the University of Auckland. And I also work as a GP in a general practice in South Auckland and Manurewa, where I do acceptance and commitment therapy consultations with patients who are referred to me from my colleagues in the clinic. This talk is Introduction 1A about focused acceptance and commitment therapy, which is acceptance and commitment therapy designed for the primary care setting. This is my version of FACT and not necessarily endorsed by other practitioners of FACT or ACT. So a new psychological approach is required in primary care. One is because of the time constraints. Two, the brief patient or client contacts, fewer follow-up visits needed, need to make the most of each session, trying to get better results in less time. And this work is designed for psychologists, counsellors, GPs, family physicians, or nurses. So what are the psychological issues in primary care? Well, some work done from the waiting room in a series of general practices in Wellington in the early 2000s found that 35.7% of patients had a mental disorder at the level of the DSM-4, so all at quite significant levels. So there's lots of pathology in a primary care clinic. Some work we've done, we found patients with a PHQ-9 score of greater than 9, which is mild or more major depression. 12.9% of patients reporting symptoms over the previous 2 weeks. So what are the medical issues? So they're the psychological issues. So there's many medical issues. Control of diabetes, control of hypertension, patients with pain, unremitting pain, patients with fatigue, insomnia, and the large group of medically unexplained symptoms, which is an issue in primary care or in general medicine and surgery. And there's invariably the psychosocial issues that go with all of this. So what's needed? So what we need is a simple model, transdiagnostic, so getting away from specific diagnoses, universal treatment principles, uniform treatment principles, needs to be evidence-based, apply to a broad range of problems, and to be done within a 30-minute consultation, and then perhaps 1 to 3 follow-up visits from that first one. So what I'm describing is focused on acceptance and commitment therapy, and this has been developed in Washington State in the United States by Dr. Kirk Stroessel and his wife, Patricia Robinson. This is a view from their vineyard in Yakima in Washington State of Mount Adams, one of the volcanoes in Washington State. And this is a picture of Kirk, who's on the left of the picture, and one of the family practice residents. So he works in a clinic in Yakima with 25,000 patients, so it's massive, and there are 4 psychologists who see patients and clients who are referred to them from their GPs. They try and keep clear templates, so they're available for what they call warm handoffs. So that's where they can refer a patient to a psychologist when they're needed. So the psychologists keep their templates clear so that they don't have lots of follow-ups. So 20 or 30 minutes in the first consult, median number of visits is 2, and they start treatment at the first visit. Because if you don't start treatment at the first visit, there's a reasonable likelihood that the patient won't come back. So why FACT, Focused Acceptance and Commitment Therapy? It's simple to learn. There are the 6 tools of ACT, which have been crunched down into 3 tools, open, aware, and engage. It's effective for mental health work, and it's also effective for physical health problems such as diabetes, smoking cessation, pain. And it's transdiagnostic, so patients don't get a label of personality disorder, depressed, anxiety. They get a label of being stuck and inflexible. And interestingly, I find patients actually quite like the term stuck because that describes how they're feeling. And words like depression and anxiety still have a pejorative sort of feeling about them in our society. There's still a little bit of stigma. And if, in terms of writing stuff in the notes from an insurance point of view, stuck is a much more benign term. So in terms of ACT, you could summarise ACT by this diagram. Essentially, we're trying to stop people from doing what are called away moves. So we want to stop them avoiding things and get them moving towards being engaged in their life. And the big problem for human beings is that we all want to be symptom-free, and this gets in the way of us having a vital life. So we want to stop the avoidance, so the arrow going to the left of your screen, and increase the approach towards a valued life going towards the right of your screen. And this is the classic ACT hexaflex with the 6 processes going on. And this can be superimposed on the 3 ACT FACT pillars. So this is the 3 FACT pillars: open, aware, and engaged. This is all based on a theory of language called relational frame theory. And essentially, the human brain is capable of recalling a series of negative events and bringing them into the present. For example, you can fail an exam at school at 8 and feel bad about that, have an argument with your mother at age 16, you can crash the family car at 21, and later when something goes wrong at work, your brain can pull all those things together and take you into a downward spiral. And this is the work originally done by Steve Hayes, and it's called relational frame theory. It's fairly complicated, and what I'm describing is a fairly simple cut-down version of it. So how language can work, it can amplify normal processes and create pathological suffering. Our mind or our brain's role is to try and problem solve and keep us alive. Now that's okay for outside things, and it helps us cross the road and drive cars and walk on bridges and footpaths, but it actually isn't very good for internal emotional things. And for those of you who work in primary care, it's not good for internal symptoms either. A patient with a headache rarely has a brain tumour or a stroke. There's usually something psychosocial going on. So the brain is good for keeping us alive. That's its main function. It's not good for internal emotions, and it's not good for internal physical symptoms as well. So in terms of FACT as a behavioural approach to health, it's part of the cognitive behavioural therapy third wave. The idea is that we can provide mental health care for all. So we have to gear ourselves up differently from how we've been providing mental health services to primary care in past. Less time is spent on rapport building. That's sort of assumed. There are fewer time-consuming assessments, and with a transdiagnostic approach, that's much easier. The problem focus is limited. We're not interested in making a DSM diagnosis, and the practice standards are those of primary care, not those of psychiatry, psychology, or internal medicine. So Kirk Stroessel has some very interesting ideas. One of his terms is the diagnosis as a distraction. Now that rings a bell to me in primary care. So the patient comes in with a headache and we start thinking of brain tumours and strokes and all that sort of stuff. Or the classic one, the 22-year-old woman comes in with chest pain. 22-year-old women don't have heart pain, don't have ischemic heart disease, but they'll get labelled with non-cardiac pain, and nobody makes a diagnosis of panic attack. The treatment can also become the distraction. I find patients, they get on antidepressants very quickly, and then we have all these discussions about side effects and withdrawal, and so over-treatment with antidepressants is becoming a modern problem, and that starts to create issues of discussion over the treatment. Another one of Stroessel's comments is that life constriction precedes mental health issues. And this has become very apparent in my work. It's very unusual to see somebody who's depressed or anxious or fatigued or in chronic pain who hasn't restricted some aspect of their life. They've stopped doing things. And one of the tasks is to get people to build up their lives again. I'm frequently saying to people, your life has shrunk down and become very small. One of my roles is to enlarge your life and get you back living a full and vital life. And the other saying he has is the solution becomes the dysfunction. And simply, we can often think of alcohol in this thing. You have a drink one night because you're feeling stressed and you start feeling more relaxed. The temptation is the next night is to have another drink or maybe 2 drinks, and then that can increase, and then the alcohol becomes the problem. So acceptance and commitment therapy has been shown in a systematic review, 2015, the reference is there, to be as good as cognitive behavioural therapy for depression and anxiety, and actually better for pain conditions. So what's involved? So a brief assessment, and then a term called creative hopelessness. What you're doing is not working. And clearly that always has to be the case, otherwise the person wouldn't be talking to you about their emotional state, their depression, their anxiety, their being stuck. The idea is to start treatment now. Warm handoffs are good if they can happen. What I do in my clinic, if I can't see a patient, is at least get them introduced to me. And if I was there full time, that would be a much easier process. So the patients at least met you, and patients often know that you're part of the clinic, so that's an advantage. So less time needed for rapport. A few visits, and then we try and get patients to do committed action, and I'll talk about that in a moment. In terms of the first visit, there are 3 books written on FACT, but none of them have a particularly good description of the first visit. I've written a manual which is an attempt at describing the first visit. So I start with the fact that the patient or the client is a capable person, and that's often quite reassuring. I find people actually sort of smile when I say that, because the fact they're coming to see you is they're often feeling not very capable. My role is to help them move towards a fuller and more valued life, and that their life be guided by their values, and that I'm not trying to get them symptom-free. Being symptom-free or reducing symptoms is a nice byproduct, but it's not the target, because if that becomes the target, you've often set an impossible standard. And then there are seven steps for the interview. So the key thing is to lower patients' expectations, and then hopefully any successes will be appreciated. This is a picture of Robin Walser. She taught me the issue of saying that the patient is a capable person. So the consult is in 3 parts. So basically the first part is the assessment. The second part is changing the relationship to the distress. And then there's the pivot point, and I'll talk about the pivot point afterwards. And then you get on to values and actions, which is sort of the treatment part. So in terms of the assessment, basically what I want to know is what patients are avoiding, person, place, or teams. A team is a thought, emotion, association, memory, or sensation. And one of the things I find quite useful is to view the client or patient through the flexibility lens, and you immediately feel in your body when somebody's not being very flexible. I then will go on to creative hopelessness, which is saying to people that what you're doing isn't working, and basically they should agree to that, otherwise you wonder why they're there. And then I go on to work, love, play, which is where the interventions come from. So work, love, play is a sheet I give to patients or clients, and it has work on a scale of 1 to 10, love in terms of friends, 1 to 10, love in terms of intimates, 1 to 10, love in terms of family, 1 to 10, and then play. And then I ask some questions about exercise, alcohol, drugs, community activity, and spiritual activities. And here's one of the ones from one of the patients I saw. So work was 3 out of 10. Work was the main problem. Friends was good. Intimates was she was separated from her alcoholic husband, but quite happy and stable with the situation. Family was very supportive, and she had restricted her life such that play had become a smaller part of her life. So one of the things I did was to get her to expand her play. I asked her to name the pain, and she said she wanted to feel not sad. And I made the point that not feeling sad is sort of a secondary emotion. What was the underlying feeling about that? I often say to people, what button is pushed when you start feeling sad or unhappy? In this particular case, the patient started crying, so I would say in that situation, if your tears were words, what would they be saying? Now that has a number of advantages. It keeps the consultation moving, and you get to the core emotion, because the core emotion is present when the patient is crying. So it's a very efficient way, and patients, they really feel like you're with them when you say that to them. If that doesn't work, then, and they can't name the pain, I sometimes get them to look at a core belief sheet. Now that comes out of CBT, it's not an ACT process, and the two big core beliefs that bother humans are helplessness or unlovable. So there's usually something in there. So if a patient can't name it themselves and there's no tears, then I get them to do the core belief sheet. So I say to patients that pain is guaranteed in life, whether that be physical, particularly as you get older, and emotional at all stages of life. And I say to patients that I can't make the pain go away, but I can work with the suffering, and that's what I would like to do. And I find patients are generally fairly accepting of that. So on to step B now, changing the relationship to the emotion. And this is where I bring in the no delete button discussion. And when I say this to patients or clients or colleagues, everybody nods knowingly. We all know there is no delete button in the human brain and that we're capable of remembering just about everything. So in terms of being able to deal with the no delete button situation, I get patients to do what I call a mindful anchor. And this is where I get the patient to put their feet on the ground and their hand on their heart. So this is an anchoring situation. I borrowed this partly from Russ Harris, an Australian GP who teaches ACT, and I get them to go through Kirk Strossel's 5 steps of being mindfully aware. And this gives the brain something constructive to do instead of ruminating or fusing with the negative experience. So this is Steve Hayes, who along with Kirk Strossel and Kelly Wilson developed ACT back in the 1980s. He was the one who came up with the no delete button. This is a picture of Russ Harris, the Australian GP who teaches ACT. So these are the present moment awareness that come out of Kirk Strossel's 2015 book. First of all, you notice the emotion, you notice the pain, perhaps not good enough, not feeling good enough. You name it, and then you soften. And I often say to patients, I want you to have a little bit of self-compassion at this point, and let them sit there for a few moments. And then I ask them just to let go a little bit, just try and let go of that negative emotion. And at that point, I often ask them how they're feeling. And if they're feeling a little bit better or more composed, then I'll ask them to do what's Kirk Strossel calls the expansion thing. And that's asking them what might be possible now with this new feeling or sensation, this new relationship to that emotion. And they may be able to talk about things they can do in the future. So here we get to the pivot point. Here the client, patient must agree that their current life is not working, and hopefully that should be a given, and are they willing to try something else? So unless they say yes to both those things, then at that point you would terminate the consultation. But in most cases, this goes quite smooth. People are quite happy to go ahead with that. And then we get on to point C, values and actions. So in terms of the ACT model, people get into difficulty when they lose contact with their values. Then social norms start to control behaviour rather than themselves, and these can be family pressures, trying to avoid hurt, trying to avoid criticism. And getting patients, clients interested in values can actually be quite an uplifting activity to do, with statements like, you can live this kind of life if you choose it. And most patients I meet haven't actually ever thought about what their values are. They'll have some idea of them, but they won't have consciously thought about them. So in terms of values and actions, I think we need to link people's values to their actions. And then I do a thing that comes out of the motivational change literature, is to get them to do a likelihood of action. So I write them out a task list, not a homework list, and ask them to tell me things they'd be willing to do. Contact a friend, name the friend, and how likely out of 10 are they to do it. And if they say less than 6 out of 10, I renegotiate. I come back and ask them. And I'm surprised the number of things years ago I would have accepted when patients would say, I'll exercise every day. And when I ask them, they say 2 out of 10, and I would have thought it was a 10 out of 10. So it's quite good to get you're getting right down to what their thinking is about how likely they are to do things. I always get them to do at least 2 things, sometimes more, not more than 4. And I'll often say to them, I've got my video camera on you next week, what will I notice you doing? So if people say, well, I'll be happier, how will I know you're being happier? So ACT is a very behavioural approach to therapy rather than cognitive. So the camera is quite a good thing. And I often say to people that you can't make yourself feel better just sitting here. You have to start doing things. And I'll get people to talk about some of their experience and let people be guided by their own experience. And I think all our experiences, we can be feeling miserable, but if we get up and do something, we start to feel better. So I think people get that pretty easily. So this would be a task list, and it's handwritten. I'll write task at the top. So I'll contact Susan, we'll go to a movie, 8 out of 10. I'll exercise 30 minutes 3 times a week, 9 out of 10. So that would be a pretty satisfactory task list. If it was 4 or 5 out of 10, I would say, well, that's probably not going to happen. Could we look at something that will happen? So in terms of actions, it actually probably doesn't matter what they do. It's just getting somebody doing anything, because human beings are great rule followers, and we all have a tendency to follow rules. And if we start going out, so when we get depressed or anxious or stuck, we are following a rule that we need to stop doing things to protect ourselves. By breaking out of that and doing something, it just gets more perspective on life and broadens things up a little bit. I usually see people a week later, and the maximum number of visits is about 4. The median for me is 2. I occasionally see people for 10 visits. That depends on what they want. So these are the some of the references. So the main book on FACT is by Kirk Stroessel and Patricia Robinson, Brief Interventions for Radical Change. And then Inside This Moment is the one with the Mindful Anchor. Excellent book on mindfulness. Real Behaviour Change in Primary Care was edited by Patricia Robinson and Kirk Stroessel. It's a slight forerunner to FACT. It doesn't actually mention FACT, but it talks about working that situation. This is ACT Made Simple, which is by Russ Harris, a pretty good overview of ACT. And this is Learning ACT by Stephen Hayes and Robin Walser. It's a very good book, and they're just in the process of updating that. So I'm just going to talk about 3 medical cases. They're all about patients with diabetes. The thing I like about patients with diabetes is that if you can sort out their psychosocial issues, they start getting improvements in their blood sugar control. So it's very immediate feedback for the patients and very immediate feedback for the physicians who are looking after them. So the first case is a man in his 40s who's been a type 1 diabetic since age of 10. He works night shift as a driver. I think that's one of the reasons why he doesn't take his insulin. And his HbA1c was 149. Less than 40 is normal. Greater than 100 is of great concern, and 149 is terrible, extreme case. So basically, he came into the office, and in 5 minutes, I was able to get him to reconsider his diabetes, basically. And I started off with saying to him what he was doing didn't seem to be helping. I looked at his values and then got him to do committed action. And the first thing he said was that he would start eating small meals, 6 out of 10. And I said, well, that's probably not going to happen. Is there something else you could do? And then I mentioned smoking, and he just said to me, back off, I don't want to talk about my smoking. And then I asked him about his values, and he said what was important was his wife, his father, and his son. So I opened my arms up like this, and I said, on this hand, we've got what's important to you in life, and over here, we've got your diabetes. And I'm confused. I don't sort of see how these things are lining up here. Do you have any thoughts about that? And he looked a bit blank. Anything you could do, taking that into consideration? And he said that, yes, I could start taking my short-acting insulin. How likely are you to do that? 8 out of 10. So I then said, well, that sounds like it's going to happen. I'll put you in touch with our nurse, which is what we did. And this is what happened with his blood sugars, basically. You can see the 149 there in July, and then the ACT consult, and the next one was 128. Still very high, but a sign that he was doing something about his diabetes. I suspect this man hadn't ever accepted that he had diabetes, basically was his problem. So his problems were psychosocial, not his insulin, and his values and my values were not the same. My values were to stop smoking and get better control of his diabetes. They weren't his values, so I think that's quite important. And then checking the likelihood of action. As I've said earlier, often I would accept what patients were going to do, and these days they'd put a score on that of 2 out of 10, which is just not going to happen. So the 7 out of 10 is quite a useful thing. So this is where the next case 2 is the diagnosis of the distraction. So this is a woman in her 40s whose anxiety was getting worse, and she'd been put on citalopram, an antidepressant from a mental health team, and she wondered if it wasn't working anymore. So here was the treatment became the distraction as well. Her PHQ was 12 and her GAD was 17. So that would suggest there's some depressive component, but a high level of anxiety. Her work love play was 85583. So not much play in her life and lots of work. And it turned out basically one of her complaints was that her husband wasn't doing enough at home. But as it transpired, she was a bit like Superwoman coming into home and saying, have you done this, have you done that? And nothing he could do would be up to her standards. So he had become a bit inert because she would come in and do everything better than him. So it was a bit like being married to Superwoman, really. So she took that on board and talked with her husband. They went away for the weekend. And then she said she slept perfectly on the Saturday night. And I was rather cheeky and I said, do you think the citalopram kicked in on Saturday night? Of course, she's going to give the credit to her medication, whereas in fact, she'd still been taking the medication and now she was feeling way, way better. So it was quite a good experience for her to realise that actually she could be better and probably in spite of the citalopram. And she said that the visit had saved her marriage, which was very satisfying. And we arranged for her to do finger prick tests. And I did wonder, because she was a fairly high energy obsessive person, whether this might cause problems. But in fact, it was very useful for her because she was able to tell when she was stressed, and she became aware that she was more stressed than she had realised because her blood sugars would be up. And this is her blood sugars. So you can see she's only fairly recently become diabetic, but it was 51 or 6.8% if you're in the US before the ACT consult, and after the ACT consult it was 44 down to 6.2%. So to come out of the diabetic range into the so-called pre-diabetes range. So the issue here was, did the citalopram kick in? Well, I suspect it had never been working. The fact that she got very anxious again on it would suggest it wasn't protective. And of course, this happens all the time with antidepressants. People get put on them for very low-level symptoms and they get better, but that's a placebo response rather than a drug response. The drug responses in mild to moderate or severe the effect sizes are very, very small. These things tend to only work, antidepressant medication generally only works for severe extreme depression. Unfortunately, her son's already on fluoxetine, so the whole family has been medicalised. I'm not sure he needs that, but I've seen him as well, and it's very hard to get this family off their antidepressant medication. And then you want to look at, well, what is the function of her anxiety? What issues does this enable her to avoid? And I think there are lots in this woman's case. So case 3 is what I call the forehead message. So this was a 60-year-old woman with diabetes who'd found out that her husband was texting an anonymous woman online, he'd met online, and she'd stopped taking her medication. So we talked about, and she confronted her husband about this activity, and he'd sort of grudgingly agreed that he would stop doing it. But she was still so angry at him, she wouldn't go into the lounge when he was in there. And I talked to her about her body language, and there's quite a good TED talk about this with Amy Cuddy on body language. So We talked about what she could do, and she agreed to start taking her medication 10 out of 10, spending time with her daughter, going back to the gym. And then I asked her to put a message on her forehead, so that when she went into the lounge, she would have on her forehead, tattooed figuratively, not actually, "I'm a great partner." And not to be afraid of going in and spending time with her husband. And this completely transformed her relationship to her husband. And this is what happened to her diabetes. So you can see it got quite high there on June 2015, 108 HbA1c, in American terms 12.0%. After the consult, it dropped down to 96, 10.9, and in November 2016 dropped down to 78, 9.3%. So it's definitely heading in the right direction. So she's getting control of her life. So the issues for her with her relationship, she didn't need more insulin or more drugs. And interestingly, her response was she'd stopped looking after herself. And it's this old situation of taking the poison and hoping the other person will die. So she was angry at her husband, but she'd stopped looking after herself. And I talked to her about stopping her wanting to be right, because she wanted to be right and her husband to be wrong. And of course, in this case, that was probably true. But I also used the old Michelle Obama saying of, when they go low, we go high. So I was encouraging her to be the adult in the relationship and be the mature one about that. And then also the likelihood of action paid off quite well with her. And so here are some resources here. There's a webinar with David Bauman and Bridget Beachy. So they're a young psychologist couple who work with Kirk Strossel in Yakima. And then there's some videos of consultations, Open, Aware and Engage, done by Kirk Strossel, Bridget and Patricia Robinson. And then there's some videos about behavioural health services in the United States.